Greetings, greetings, greetings. How you doing? This is Kinesiology 236, Chapter 8, Hip Joint and Pelvic Girdle. All right, so now here's the deal. What I've done is I've gone through and I've kind of parsed out the good information here for you, and you'll see in this video, I've kind of tied it all together towards the end and color codified it. Hopefully it makes sense. All right, so, and also this is going to be a beast of a presentation, so there might be like 2 here, perhaps 3 presentations. Okay. So when you look at the hip and hip joint and the pelvic girdle, you have to realize that it's a really stable and strong joint. You have a very high weight-bearing effect on this area of the body. Matter of fact, all the weight of the body is carried through the hip joint. And as a result, it's a very strong joint, but it's also very dexterous as well. Much like the shoulder joint, it can articulate a number of different ways. That's not to say that they're exactly comparable, because they are different joints after all. So don't confuse that logic, but just realize that they're both highly mobile. The hip joint is an anethroidal joint, it's a ball and socket type joint, and it articulates in a number of different planes of movement, and it's super duper strong, but it is different than the shoulder joint in terms of how it's set up. Please just differentiate those two and you'll be fine. So you have the femur itself, which connects into the acetabulum in the pelvic girdle. And so when you look at this, you have the articulating surface is in the acetabulum. And when you start to evaluate the hip itself and the actual bone itself, the femur comes up, goes through the neck of the femur, the femoral neck in this case, and the femoral head fits right into the ilium in what's called the acetabulum. The acetabulum is that depression right there, much like the glenoid fossa on the shoulder. There is a depression that the head of the bone articulates fits into. So the biggies that you probably want to have yourself wrapped around are on the left here: sacrum, ilium, sacroiliac joints, acetabulum, coccyx, obturator foramen, symphysis pubis, femur, and greater and lesser trochanter. And you'll see a couple quiz questions on this where I'll black these out, and you'll have to, or white them out in this case, and you'll have to kind of guess what is A, what is B, what is C, what is D, what is the acetabulum versus the sacrum versus the iliac crest. So the bones themselves in the pelvis, when you look at the actual bones that comprise the pelvis itself, it's the sacrum and the ilium. And the sacroiliac joint is usually an area where many of your clients and patients will have issues, and it's just how the body is made. I will often describe this sacroiliac joint right here is kind of a tongue and groove. You have the 2 ears of the ilium, one on each side, think like mouse ears, and then the tongue fits right down in between them. So I'll literally do this with clients where I'll have my 2 hands up and look like ears side by side, and I'll have my client put their hand down, fingers down in between my 2 hands, so they have an understanding of what this joint looks like. The important part of this is realize all the building blocks of the spine stack right on top of the sacrum. So if you have some type of SI joint dysfunction, that's going to translate up the kinetic chain up through the spine, up through the lumbar region, up to the thoracic region, cervical region, etc. And so oftentimes if there's dysfunction in this area, there'll be dysfunction further up. I'm just going to buzz through this one here, and we already know what type of joint it is, so you're fine there. This one, I'll let you read through this at your leisure when you have a chance. And same thing with here in terms of what type of ligaments are there and how they articulate around. But the thing I want to just point out to you is notice this articulation where you have this one ischiofemoral ligament comes out and attaches, and the other comes out and attaches behind in the iliofemoral ligament. So realize there are 2 different ligaments here, ischio and ilio. Now I'll let you read through this and kind of get a hang of the different types of movement, but realize when you have one type of action, there's different actions that have to happen. So in anterior rotation, you're going to get in the lumbar region extension, right hip flexion, left hip flexion. So kind of go through this and have an understanding of how, if you're doing this movement, pelvic rotation, right transverse rotation, this is what's going to happen across the rest of the hip and pelvis complex. I love this example in the book. I think it's great in terms of describing anterior posterior pelvic tilt. I like how they use a steering wheel as an example, and they also use the example further here in terms of right and lateral pelvic rotation. I think this is also fantastic in terms of trying to understand it. And keep in mind, we talked about running and walking and how when a person runs or walks, there's different degrees of anterior and posterior pelvic tilt and rotational movement when a person walks. And I think the steering wheel example is a great example of that. With this, if we were in class, I would go through this example, but I had actually a client. She was a dancer and she had to have a labrum repaired on her hip and she could not do any weight bearing exercises. So we actually had to do exercise where I applied manual resistance to the hips on the anterior side of her body. And I just worked on left and right transverse pelvic rotation, first static because we had to keep her immobile. And I would just apply resistance with my hands on the hips itself. And then I had her actually work through a range of motion against the manual resistance of my hands on her hips. It was kind of cool to work with her because it forced me to really think of the hips in a slightly different way and how I'd work with clients. Good example here of hip flexion. They have different GIFs in here. The one thing I want to point out with all these little GIFs, when you look at them, realize even though we're doing hip flexion, notice what happens further upstream. You have a lower dotted curve, and as she brings the hips up, the pelvis shifts, the building blocks shift. That'll hold true here in hip extension. That'll hold true here in abduction. And notice there's a weight transfer from the middle of the foot out to probably like the 4th digit or 5th digit. Adduction coming across the body, and it's very difficult to do adduction and abduction without having some type of rotation in the hip itself. Hip external and internal rotation. So what I want to get across here is when you do external rotation, notice you're externally rotating the femur, but you have an internal movement pattern, meaning going from lateral to medial of the ankle. Sometimes it gets people a little confused when they see this, and like, how can that be external rotation when the foot's going inward? It's not the foot you're focusing on, it's the actual femur that you're focusing on. And same thing with internal. Got it? Diagonal abduction. And then diagonal abduction, notice the hips. Notice how your hips are kind of coming across, rotating as the foot comes across the body. That diagonal plane of movement. With different movement patterns and anterior pelvic rotation, you'll oftentimes see this in people who do a ton of cycle classes. Their hip flexors, and I'll point this out a little bit later on, are super tight, and they end up coming out of class not so much walking, but waddling like a duck, just because everything up front is so dang tight. They're in hip flexion, and they're loading up those hip flexors over and over and over a couple thousand times in a class every time they push down on a pedal. And then posterior, again, notice as you tilt the pelvis, what happens to the building blocks. You go from a lower dotted curve, exaggerated lower dotted curve here, an anterior pelvic tilt, to where you flatten out. And notice also what happens further up the chain when you get to the thoracic region. It gets almost kyphotic. Hell, it does get kyphotic. I put this in for you guys for your benefit. And when you get to this time of year, actually more like December, you'll have your clients will come in and they'll want to work golf movements. And you'll oftentimes see individuals who will grab a torso rotation machine and they'll do this. I'm going to rotate, which ain't so bad. It's a closed chain kinetic exercise. Let me pause that. Closed chain, both feet are on the ground. Resistance is offered laterally, but notice it's more in a transverse plane, slightly uphill movement pattern, right? Not so bad. It's going to work the muscles in the midsection, but it's not specific to golf. When we look at the video to the right, notice what we're doing here. It's a closed chain, much like our partner to the left. The feet are locked in. You're now holding a cable. The cable is now staying stable, and it ends up being anchor points, and what you're focusing on is the segmentation of the swing. The actual hips are rotating against resistance. And right now, the way this positioning is set up, you replay that. This is about 90 degrees nose to hands to the cable, and the toes are running parallel with the cable. You can open your stance or close your stance, and that will change how the resistance feels. Much like over here, if you open your stance or close your stance, it will change how the resistance feels. So to that end, when you look at golfers, I'm going to go ahead and kick over to the next slide here. When you look at golfers and you look at the video to the left, there's one gentleman in a slow-mo. He's about 2 minutes in, if I remember correctly. But what I want you to pay attention to is on a right-handed golfer, pay attention to the left hip. Nice music, right? Watch this left hip. The club is still going up and back. The hips are rotating. Now the hip is going to rotate forward, and now the club is coming through. very much like what you see over here in terms of the hip rotating, rotating, rotating. Now this is actually a pretty good one too. You'll see the hip kind of kick through first. He'll rotate after he pauses and pull on through. So it's not to say that the other exercise was wrong, vastly wrong. It's Phil Mickelson. Not vastly wrong, but realize you can do better by segmenting this. This is actually a pretty good one right here with this guy in the blue shirt. Watch the belt rotating, and now the club comes through. See that? And what I'm getting after is with your golfers, when they come in, you might have to work on mobility, stability, and then be able to work on this very dynamic mobility seen in the hips. And the hips are coming through as the club head is coming down. So just kind of wrap yourself around that segmentation concept. I'll move along here. The book does a pretty good job explaining this, and it breaks it down into anterior, posterior, medial, and lateral. And there are 7 two-joint muscles that have an action across the hip and the knee. You have rectus femoris, sartorius, gracialis, semitendinosus, semimembranosus, biceps femoris, tensor fasciae latae. And when you look at these, like the rectus femoris is part of the knee extension group, right? And there's another couple people that come to the party for knee extension, mostly the vastus group, right? So you got vastus medialis, vastus lateralis. You know, those guys come to the party to help extend, but realize rectus femoris is a two-joint muscle. Sartorius, gracialis, semitendinosus, membranosus, etc. And you'll see this a little bit later on how I color codified these. And this was put in for you guys for your benefit, right? So notice you have hip flexion, knee extension, sartorius, hip flexion, knee flexion. As you go down to the hamstring group down here, hip extension, knee flexion, hip extension, knee flexion. So notice these, semitendinosus, membranosus, biceps femoris, are going to be antagonistic muscles to the rectus femoris and the quadricep group. And what I did was on this, I broke these out in the book, had these listed, but I just color coded them so it's easier for you to see. So you have the primary hip flexion muscles. Some of these will not be represented because they might be deep and they might not be seen on the renderings that they have that they provided. But what I did was I put them in red so you can see them. Iliopsoas, pectineus, rectus femoris, sartorius. And if you want, you can just quiz yourself right here, which one is a two-joint that comes across the knee that does knee extension? Rectus femoris. Comes down, attached to the patellar tendon, moves this sesamoid bone right in here that's embedded in the tendon to help you extend the knee. In blue here, adductor brevis, longus, magnus, gracialis. Got those. Got green here for hip extension. And you'll see that like the external rotators are not shown because they are deep to glute max and glute med and glute min. But those are the often forgotten powerhouses in the hip. And when people say they're doing glute work, they usually do squats first as opposed to working these rotators. And they're hugely important. I'll talk to regarding them in a little bit here. When you look at abduction, you got glute med, glute min, and notice how those movement patterns for glute med and min are different than glute max, right? So glute max is more of an extensor, where this is more an abductor. And also the external rotators. Got it? Get it? Good? Okay. The biggie I want to get across here in a minute and a half we have left on this slide is when you look at the region of the hip flexors and the iliac region, you have psoas minor and psoas major. Look at where they actually start. See where they originate? They originate on the lumbar area of the spine, and they come down and they cross the hip flexor. Remember I was talking about those people who waddle out of a cycle class looking like a duck? It's because they're in hip flexion. They're doing rep after rep after rep after rep in hip flexion, and they are overloading these, and they get so tight, so strong, so short, that they end up having these tugging on the back part of the spine or front part of the spine, excuse me, and it tugs them almost forward into hip flexion. And so many times with cyclists, you have to do a lot of work on psoas, minor and major, and iliopsoas all in general, and you have to work on that in terms of flexibility. I have about 15 seconds left, and what I'm going to do is I'm going to pause this and I'm going to go ahead and fire back up with another video in a second. Hold on.